Thank you.
Thank you, Dr. Varshini. Thank you for sharing interesting cases. I think due to paucity of time, I think we'll request REENA to Dr. REENA. Any questions meantime to Dr. Varshini or any of the panelists who have presented so far? Dr. REENA is a professor at RIO2022 Rohtak. She did her post-graduation from Jammu Medical College and she is a gold medalist. She has several publications to her name and she has presented many papers and faculty talks. She is the recipient of Best Case Presentation at Joint DOS SPOCI Conference 2017, Best Poster at Annual SPOCI Conference and Free Paper at North Zone Conference in 2019. And also she has won Best Poster last year at Annual SPOCI Conference. So with this, I'll invite Dr. REENA. Her talk is on interesting cases in unexplained visual loss.
Thank you, Dr. Rishikesh, for giving me an opportunity to be part of this instruction course. So I'll be discussing a few assorted interesting cases and keeping in mind the general ophthalmologists also, which we have in our audience today. So let's start with the first case. She was a 14-year-old female who presented with diminution of vision and in both eyes and difficulty in reading and writing since the last 1 year. Her best corrected visual acuity was 612 parts in both eyes, and anterior segment evaluation intraocular pressure was absolutely normal. So this is the fundus picture. You can see the fundus picture on one go. It appears to be absolutely normal. So the discs were absolutely fine, unremarkable fundus. The only thing we saw was there were some RPE alterations which were present at the macula. So you can see some RPE alterations at the macula. And then, like Dr. Varshini was mentioning, autofluorescence is a very accessible and non-invasive modality which is available nowadays. It helps you to clinch the diagnosis on the spot. So what we see here is an area of hyperfluorescence, a circular round area of hyperfluorescence and a small hypofluorescent central part. So it gives you, then we went back and we did indirect ophthalmoscopy again, and very closely when we saw, there were a few yellowish white flecks which were present, and that is typical of Stargardt's disease. So we sent the patient for genetic counseling and ERG, and Stargardt's disease was confirmed. Not going to the details of the disease because it's already been discussed. So this is a second interesting case. 16 years old male who presented with diminution of vision in the right eye since 2 weeks. On examination, his best corrected visual acuity was 618 in the right eye. And on slit lamp biomicroscopy, the AC was quiet in both eyes. There were occasional witch cells which were present. And on 78 diopter slit lamp examination, we found that the optic disc was normal and there was just a dull foveal reflex. Indirect ophthalmoscopy was done and the fundus appeared grossly normal with only some mid-peripheral venous sheathing which was noted. So if you see the fundus picture of this patient, it appears to be normal, right? Only you can say there's a dull foveal reflex which is there. Again, this gives you a normal fundus picture, autofluorescence. Then we did the OCT of the patient. On OCT, you see there is gross cystoid macular edema which is there. And left eye was absolutely unremarkable. We did the FFA of the patient. This is left eye which is normal. The right eye, if you see, there is a very small leakage in the inferior arcade which is present in the mid-periphery. So this was diagnosed as a case of vasculitis. So we started all the battery of lab investigations were done which came out to be normal. We started the patient in topical NSAIDs and systemic steroids were given and with the weekly tapering, and so the patient's visual acuity improved. Another interesting case, it's a 16-year-old male who presented with mild blurring of vision in the right eye and loss of the superior field in the left eye since the last 2 to 3 weeks. The patient also had a past history of DVT and he was under treatment. His best corrected visual acuity was 660 in the right eye and it was around 69 in the left eye. On slit lamp biomicroscopy, the right eye showed occasional AC cells and 1+ witch cells. So fundus examination was done. And this is the right eye picture of the patient. You see a BRVO here, right? And there is peripheral venous sheathing, the perivenous sheathing which is present in this patient. So this is the right eye of the picture in which the patient had decreased vision of 6/60. What we see here is there is a leakage which is present along the vessels, and then they're hypofluorescent. Some capillary non-perfusion areas are also there. And on OCT, we see there is gross macular edema, and there is NSD as well. So we were sure that the patient had a BRVO, inferotemporal BRVO with macular edema. But what about the left eye? The left eye, the fundus was absolutely normal. So there was no, we were not able to find the cause of decreased vision in the left eye. And what was the cause of loss of the superior field in the left eye? So if we see this, on FFA, it appears to be normal. Now what comes to your mind if you see there's nothing on FFA, everything is normal? Now which is the latest modality which will help us in making the diagnosis? So it's the role of OCTA. This is the OCTA of the right eye. This is a color-coded OCTA where we can see there is a inferior temporal BRVO which is seen. Now if we come and see the left eye OCTA, now this hemifield, you can see inferior part, there is loss of perfusion, loss of vascular perfusion is there, which we can see here, and it is very clearly seen in the color-coded OCTA. So there was a loss of vascular perfusion in the inferior part. And then on systemic examination, this was which was visible. These are, anyone from the audience would like to comment on the diagnosis? This is an interactive session, right? So we can all chip in. If anyone wants to make a comment. Okay, so these are the oral ephthous ulcers. Now I think it's pretty clear now, right? What's the diagnosis? Yeah. So then we went back, we got the investigations done, and then HLA-B51 was advised to the patient, and it came positive. So this was basically, it was an ocular Behçet's disease in which the right eye inferotemporal BRVO with macular edema was present. In the left eye, he had a hemi-CRAO. So the patient was started on systemic steroids, and after that the patient was started on immunosuppressants. So he was taking azathioprine. Then we took help of internist, and lately this patient is on biologicals and he's doing pretty well with adalimumab. So subcutaneous injections are being given and his vision is also recovered. This is the last case. This is a 23-year-old female patient who reported with diminution of vision in both eyes since the past 7 to 10 days. There was pain in eyes and ocular movement, a history of pulsatile headache in the occipital region that increased with change in posture. She was an old case of chronic kidney disease since the patient was 5 years of age. She was not on any regular treatment. There was a history of stunted growth, fatigability, and breathlessness on exertion. No history of hypertension, diabetes, or tuberculosis. No history of fever, neck rigidity, or joint pains, or no significant autoimmune disorder. On examination, her vision in the right eye was finger count at 1 meter. In the left eye was 636. Painful ocular movements were there. Grade 3 RAPD was there in the right eye. And color vision was abnormal. Anterior segment evaluation was unremarkable. On posterior segment evaluation, she had a presence of bilateral optic disc edema. Visual fields were severely depressed. Her blood counts were around 4.4 grams of hemoglobin was there, so she was severely anemic. And all other blood inflammatory markers were within normal limits. And she was negative for CSF analysis for anti-NMO and anti-MOG antibodies. MRI was done and it showed diffuse hyperintensity in bilateral optic nerves with mildly increased bulk suggesting of optic neuritis. So this patient was diagnosed as optic neuritis, which was associated with nephropathy and with severe anemia. The patient was started on treatment as per the ONTT trial. RAPD improved, but visual acuity did not improve. At this point, we went ahead and did a vitamin B12 assay, and she was diagnosed with vitamin B12 deficiency. So we started her on IM cyanocobalamin, and it was followed by oral maintenance therapy. To our surprise, we found that after the vitamin B12 supplementation was given, the patient's visual acuity and visual fields, they improved. with a residual defective color vision. So this is how vision improved to 618 in the right eye and 612 in the left eye. This is the improvement in the visual fields which we found. So visual loss is a rare manifestation of vitamin B12 deficiency, which in our case was the main complaint in the patient, who was a case of chronic kidney disease with anemia. The exact pathophysiological mechanism due to vitamin B12 deficiency is not known, but most of the studies say it can be combination of optic neuritis and neuropathy together. So there are a lot of published articles also which have reported that the concurrence of hypotension and anemia also predisposes to optic nerve infarct. And there was a case in which the patient had similar to optic neuropathy in pernicious anemia, and his vision regained after he was treated with vitamin B12. So treatment of the ophthalmological involvement secondary to vitamin B12 deficiency is prompt vitamin replacement. Through various studies, it has been proven that early and aggressive replacement of vitamin B12 aids in visual recovery, and best clinical response is seen within 3 months of replacement. So in many studies done earlier, following vitamin replacement therapy, visual symptoms have either improved or they have resolved entirely. So whenever we see a patient who comes to us with unexplained vision loss, it needs a comprehensive history taking and a comprehensive ocular examination. After you have done the visual acuity and the refraction part is done, a detailed comprehensive anterior segment evaluation, slit lamp biomicroscopy, fundus examination, indirect ophthalmoscopy is done. This should be supported with ancillary testing. Autofluorescence is a very useful tool because it is non-invasive. Then you can even take the help of OCTA in clenching diagnosis if there is something which is still not explained. Obviously, it has to be supported by a battery of lab investigations. Thank you so much.
Thank you, Dr. REENA. Thank you for sharing interesting cases, especially the case of Behçet's disease. That was actually really